So I'd like to present the case of early mitral valve repair as a better treatment of choice for asymptomatic severe mitral regurgitation due to degenerative mitral valve disease. Now, why is there a debate at all? There are no randomized trials comparing the two therapeutic approaches, although there is one ongoing study, a multi-center study in the Netherlands. There's a small number of small to moderate-sized prospective observational studies, one of which was done by Rosenach. It's a relatively small, single-arm prospective observational study of watchful waiting. It's a single arm with guidelines-driven surgery when needed. There are multiple retrospective observational studies in which the follow-up and the surgical decisions were made by the personal physician, and there are major advantages that there are relatively large number of patients, and some of them being multi-center. And Rafael Rosenach talked about the MIDA and the problems with the MIDA, the major advantage with the MIDA registry, the very high number of patients. The difference in numbers between the various publications relate both to recruitment of additional centers, but also to specific inclusion criteria in each of the studies that were performed within the same database. So it's not just random numbers. Now, these are the ESC and the ACCIAHA guidelines for a surgical intervention with chronic severe primary MR. First of all, symptoms, then asymptomatic LV dysfunction or left ventricular end-systolic enlargement, which is not only reflective of left ventricular enlargement, but also of a left ventricular systolic dysfunction. These are Class A recommendations, and nuance of atrial fibrillation or resting pulmonary hypertension as 2A recommendations. Now, this is the first study published from the MIDA registry. Almost 400 patients in 4 European centers with a flaying mitral valve, mostly degenerative. I agree, this is not a study of asymptomatic patients. Only about a quarter were in NIHA 1 with an ejection fraction above 60. Please note that within these all comers, this is a real good snapshot of degenerative mitral valve disease. During a follow-up of 8 years, about 30% developed AFib, 50 heart failure, and almost 90% eventually underwent surgery, most of them within the first period of follow-up. The predictors of overall cardiac events, cardiovascular death, heart failure, or AFib, were age, higher NIA class, and lower ejection fraction. So this is really not relevant to the asymptomatic patient group that we're trying to talk about. When we look at the benefits of surgery in these patients, valve surgery was eventually performed in about 80% of patients. Most of them underwent surgery because of symptoms with prophylactic early surgery in a small minority of patients. The median time to operation in this registry was 2 months. So most people that we see with a flail leaflet get surgery mainly for symptoms within the first 2 months. An excellent perioperative mortality of less than 1%. Valve repair in only 80%, but much higher than what is seen in everyday life. And the beneficial effect of mitral valve surgery in these patients was analyzed as a time-dependent variable with the hazard ratio adjusted for age, NIA class, and ejection fraction. And here we can see that comparing medical therapy to surgical treatment, surgery is better with a reduced hazard ratio of multiple cardiovascular endpoints, and within the patient who were operated, mitral valve repair seemed to be better than mitral valve replacement. There is a subgroup analysis of patients that have normal ejection fraction and no symptoms, and even in this subgroup, it appears that there's better outcome with relatively early, within a year of mitral valve surgery. These are, again, data that have their limitations. Again, a large group of about 450 patients published from the Mayo Clinic who were asymptomatic at baseline, mainly prolapse. I agree with Dr. Rosenach that some of them had slight left ventricular systolic dysfunction, but overall the ejection fraction was 70% on average. So these were patients that overall had a very good left ventricular ejection fraction. And one can see that if we look at death from cardiac causes, the mitral valve regurgitation, which is severe, is associated with significant increased risk of death and a very significant increased risk of cardiac events, which include death, heart failure, or new atrial fibrillation, more than 60% during a 5-year follow-up. So what we can conclude from these limited studies, and I agree that they are limited, that severe primary MR is a bad disease. It is associated with increased risk for multiple adverse cardiovascular events, including an increased risk of death. And the risk appears to be higher even in patients who are initially asymptomatic, like the Serrano paper I just presented. Valve surgery, looking at a snapshot of the MIDA, is needed in almost all patients during intermediate follow-up, and most operations are performed shortly after diagnosis. And surgery appears to have a beneficial effect on outcome, and this effect is primarily driven by valve repair. So is there a role for prophylactic early surgery? The first study that really pushed this concept, again, came from the Mayo Clinic. It has many, many limitations. More than 200 patients with a flayed mitral valve. Early surgery was defined as surgery within 1 month of enrollment. About 30% underwent early surgery. The others underwent conservative management with surgery later on when needed. And one can see that cardiac death was higher in patients with a conservative approach, and heart failure incidence was much higher. But again, the patients that they referred to early surgery were different than those that underwent conservative management. They were younger, lesser comorbidity, and they had more indications for surgery. They were more symptomatic and fibrillation. So the indications for surgery were higher, and the surgical risk was lower in the patient. So this doesn't really answer our question whether early mitral surgery is also beneficial in patients without guideline indications for surgery. Now, when we compare these two strategies, and we're not comparing surgery versus conservative therapy. We're comparing the strategy of early surgery when there's no indication, no clear guidelines indications for surgery, versus follow-up and then surgery when there is a clear indication. Now, when we adopt the watchful wasting strategy, we assume that it is a safe strategy, but nothing really bad can go during follow-up. And if something bad does occur, it is fully reversible. And as I showed you, that's not necessarily the case. But also, if we adopt the early surgery, we have several assumptions. First, that valve repair is feasible. I think we could all agree that valve replacement in an asymptomatic patient with good LV is inappropriate as prophylactic therapy. Because valve prosthesis is a bad disease by itself. So we assume that if the patient is subjected to early surgery, the valve repair is feasible. We also assume that successful surgery not only normalizes valve function, because that's not really important to the patient, but it does have a favorable effect on clinical outcome. I would like to first return to Dr. Rosenhack's really landmark paper and look at it in detail. This was these patients in this study, a bit more than 100 patients, a relatively small study, were enrolled and followed up prospectively. It is a study of degenerative mitral valve disease with severe MAR. Flayed leaflet was not a requirement. It was present in less than 50% of patients. The quantification of MR was not done, and a non-quantitative but integrative approach for MR assessment was done in order to say that these patients indeed had severe MR. When I read the different details, I can say that many of the criteria for defining severe MR in the study were not really specific to define severe MR. These patients initially did not have either class 1 or 2A indication for surgery. The patients were followed up very, very well and referred to surgery when class 1 or 2A recommendations occurred. Let's look some at the details. First of all, the age of the patients was very young. They were in the 50s. This is not real-world experience. Patients with flayed leaflets in many, many registries are in their 60s. So this is a young population, presumably with very low comorbidity. Second, if we look at the dimensions of the left ventricle, you can see that it is on the border of normal left ventricular end-diastolic diameter, which means that probably some of them did not have severe MAR, and overall these are patients not with very severe MAR. And one looks at the left ventricular end, the systolic diameter, you can see that it's far, far below the cutoff of 40 millimeters, certainly the 45 ESC guidelines, millimeters. So these are young, healthy patients with severe but not very severe MAR, some of them perhaps not with severe MAR, and excellent LV function. So the results should be taken into account. Please characteristics of the patients. This was shown already that there's no increased risk of death, but over the 8-year follow-up, about half of the patients developed primarily symptoms, which led to surgery, but also other indications for surgery. And there was no statistically significant difference between the flailed leaflet and the patient with prolapse, but there is a trend to worse outcome in patients with a flailed leaflet. Surgery was performed in 35 patients, valve repair in only 80-something percent of patients. It's a good figure. It's a very good figure overall, but it's far from ideal. And if we look at what happened to patients who operated, 12 patients, almost more than 30%, had persistent symptoms after surgery. They were mild in all cases, but they remained symptomatic after surgery. And 4 patients had LV dysfunction, the severity of which is not mentioned in the paper. So about 40 of operated patients had bad results after surgery, either persistent symptoms or LV dysfunction, and this is written in the small letters at the end of one of the paragraphs. And not mentioned, but Dr. Rosenbach in his thoughts. So the conclusion from this paper, and I'm citing the paper, and then I'll tell you what my conclusions are, that asymptomatic patients with severe degenerative MR can be safely followed until either symptoms occur or currently recommended cutoff values for LV size, LV function, or pulmonary hypertension are reached. This management strategy is associated with good perioperative and post-operative outcome, but requires careful follow-up. I agree only with the last 4 words, but requires regular, careful follow-up. The way I look at the same data, in a small observational study, mortality during intermediate term follow-up was low, in a low, I would say a very low risk group of young, healthy patients, with severe MR, but not very severe MR, and perhaps not all of them had very severe MR, who were initially asymptomatic. Valve surgery that was performed according to the class 1 and 2A indications, with valve repair in only 80% of these patients, was associated with unfavorable outcomes, including about a 40% frequency of residual post-operative symptoms and left ventricular dysfunction to a degree that we're not aware of from the paper. And these suboptimal results are obtained despite careful and regular follow-up Vienna type, which is not necessarily the Middle Eastern type or other world type. So if we are in favor of watchful waiting, we have to ask ourselves, what could go wrong? Well, symptoms can occur, and these are data from the Mayo Clinic, almost 500 patients that were operated for chronic MR, mainly degenerative disease. First of all, if they were operated when they were in advanced NIHA class, the operative mortality was 10 times higher than if they were operated when the NIHA class was low. Second, if they were operated when the NIHA class was 1 or 2, their expected survival was the same as the general population, where the survival was worse for the age-matched population if they were operated with advanced symptoms. And this difference between the survival in NIHA 1, 2 versus 3, 4 was evident even in patients with good ejection fraction, and even in the subgroup that underwent successful repair. So being operated when the symptoms are already there is bad and affects prognosis long term. What else could go wrong? LV dysfunction can develop. These are data from the MIDA studies in registry, 2 separate studies from different time periods that explains the different number of patients. But we can see that if the patients are operated, the patients are seen, and this is the EF at the beginning of follow-up, with an EF that is below 60 and certainly below 50. This is associated with increased hazard of death, and this hazard of death is still very significant even after adjusting to multiple parameters, including the symptoms. And a similar thing can be seen when the end systolic diameter increases, and this actually may suggest that we should not wait for the European cutoff of 45, but maybe we should start thinking of surgery as a class 1 indication when the end systolic diameter is 40 and above. So LV dysfunction is a bad thing, and it affects long-term prognosis in these patients, even after you adjust for other clinical parameters that affect the outcome, including symptoms. Now, this is a typical watchful waiting patient. I'm sure that everyone who treats patients with valvular disease sees these occasionally. This is a 78-year-old patient, flail P2, small segment. We expected that the feasibility of repair was very high. He was physically very active and truly asymptomatic. And actually, he did our life, made our life easy. He was not interested in prophylactic surgery. This is an echo follow-up, October 2013, January 2014, EF above 60, end-systolic diameter less than 45. This is his valve. You can see this flail segment. I hope you see it okay. And it's actually quite a small flail segment. You can hardly see in this 3D echo. And it was really amenable to repair. He came to the scheduled 6-month visit with minimal symptoms. Actually, he did not admit of being symptomatic. It was his wife saying that it's not the same in the last few months. And this is the F, 55 to 60, end-systolic diameter of significant change. Certainly justifying surgery according to the guidelines. And he was referred to valve surgery, underwent successful valve repair, and he's asymptomatic after surgery. But this is EZF, immediately after surgery, and it's a few months after surgery, and this is how his ventricle looks. This was a normal contracting ventricle before the last visit that LV dysfunction with minimal symptoms appeared. So this patient had persistent LV dysfunction because of leg surgery. And I'm sure that many of you have this experience also. Fortunately, not too often, but this is not something very rare. Now, what else could go wrong? Left atrial remodeling and atrial fibrillation can occur, and these are associated with increased risk of death. Again, a large atrium above 50 millimeters is associated with increased risk of death, even after adjusting for symptoms and ejection fraction. And if the patient eventually develops atrial fibrillation, his outcome will be worse. Pulmonary hypertension is the same. Again, data from the MIDA that the outcome of patients, both in terms of survival and incidence of heart failure, is worse if the patient has at baseline a pulmonary hypertension above 50 millimeters of mercury. And these associations were independent predictors of either survival or heart failure, even after adjusting for NIHA class, ejection fraction, and atrial fibrillation. So waiting for surgical indications is associated with increased risk. Surgical mortality appears to be higher, and long-term outcome is worse. So can we improve it by early surgery? I would like to look at the study that was already presented. About 1,000 patients from the MIDA registry without class 1 indication for surgery. They had no heart failure symptoms, no ejection fraction below 60, and all of their end-systolic diameters were less than 40. Early surgery was indeed defined arbitrarily within 3 months, but that appears to be a reasonable period, in my opinion at least. The median time to surgery was much less than that. It was 14 days. Almost half of the patients underwent early surgery. The other half underwent initial medical therapy, but 60% of them eventually had late surgery. A median time of a bit more than a year and a half. So even those that are initially treated conservatively will eventually very soon, and these are initially asymptomatic patients with good LV, they will very soon, within a short period, need surgery. In order to make the analysis a bit better, they use propensity score matching, using a score of more than 30 parameters that are predictive of early surgery, and notably, this study that involved 6 centers was excellent, more than 90%. And these are the data looking at yours shown only the upper part. I'd like also to show you the data on heart failure. This is the total cohort of more than 1,000 patients. This is the propensity score match cohort of more than 600 patients, showing that there's an advantage both in survival, but also a larger advantage in terms of heart failure in the patient that is treated by early surgery versus medical therapy. And this is true in the total cohort as well as the propensity score match comparison. And if you look at just at the numbers, look at the number of the patients dying. These are the patients that are initially treated medically. Look at the numbers and compare them to those that underwent early surgery, much higher numbers, and eventually a mortality reduction which is consistent and still around in the area of 50% after 5 years. And when patients that had class 2 indications for surgery, those with atrial fibrillation and pulmonary hypertension, a smaller patient, but if you take them out, if you look just at the patient that had no class 2 triggers, you can see that the same numbers, same advantage of early surgery is seen, and there's a reduction in the risk of mortality of more than 50%. And even if you take patients that have these vague symptoms, mild atypical dyspnea, palpitations, atypical chest pain, if you take them out and look at the patient that are completely asymptomatic, you can see a clear survival advantage by using early surgery of more than 50% less mortality during follow-up in the long-term follow-up. And I'd like to once again show a study and look at it a bit differently. This is a prospective Korean, South Korean study of more than 400, about 4 times larger than Dr. Rosenach's study of asymptomatic, very young patients. This is a population very similar to Dr. Rosenach's. All of them with normal ejection fraction. Flail again, less than 50%. Early surgery was defined as surgery within 6 months. You can doubt whether that's okay. It was non-randomized. It was patients were sent to surgery according to physician's preference. Conservative therapy was in about 2/3 of patients, with surgery according to guidelines in about 1/4 of these patients. Look at these. These are data from the prospective score match, the subpopulation of this study, showing really perfect results for the operating patients versus not as good and significantly worse results in terms of event-free survival, events defined and composite endpoint of death, cardiac death, operative death, reoperation, and urgent heart failure hospitalization. This was the main parameter that drove the significant difference between the group. But as shown previously, if the patient needs hospitalization for heart failure, this is severe heart failure, and severe heart failure by itself both increases the risk of surgery and eventually affects outcome. So I'd like to end with a few short things. Looking at the guidelines, these are the ESC from 2012 and ACCIAHA from 2014. They did not have all the data that was presented here of the latest studies. The ACCIAHA guidelines give a class 2A level of evidence B recommendation for mitral valve surgery in asymptomatic patient with preserved lung function. If a successful, more than 95% and durable mitral valve repair can be achieved with a very, very low mortality, necessarily done at heart valve centers of experience. When you look at the European guidelines, they're a bit more vague and probably more realistic in their way they define it. A high likelihood of durable repair and low surgical risk, and they accept as a new 2A indication if the patient has a flail leaflet and an LV function that is not perfect, that is a bit above the 40 millimeter guidelines, still not within the classic European 45 millimeter guideline. Now let's see what happens to the guidelines. These are the ESC guidelines, comparison between the previous set and this set. In the first set, 2007, the high likelihood of durable repair, low surgical risk was a 2B recommendation. And in the new set of guidelines, if it's a flail leaflet and LV function is not perfect, they are willing to recommend it in a higher recommendation class. And what happened to the American guidelines? They became more strict. In the previous set of guidelines, there was a 2A indication for surgery if a successful repair of more than 9% to be achieved at experienced centers. Very loose requirement, but in these new guidelines, it has to be a successful and durable repair of more than 95% with very low mortality at very well experienced centers. So it's actually, we're two cardiologists debating, but whoever should actually resolve the problem is the surgeon. It's all a matter of surgical experience. So I would like to summarize. Early surgery is indeed an appropriate therapy. It is an appropriate therapy for patients with very severe harm, especially with flail leaflets. In ideal surgical candidates, those that are expected to have less than 1% of surgical mortality, and I think many centers can achieve that. Mainly young patients. I don't think I would send a 70-year-old patient, as I presented previously, to a prophylactic cardiac surgery. And also, only when the expected successful and durable repair is very high. And I urge you all not to hear your surgeons telling you stories on how good they are, but really to present hard data, at least on the early results of their surgery, and questionably whether they can give you results on the long term of their surgery. And maybe we should restrict this just to posterior leaflet pathology, because if the surgeon tells you overall I can repair 80% of patients, of course I will not send them. But if you say I can repair 90 or even 95% of patients with posterior leaflet or P2, then I know if the patient has a P2 and these are its numbers, I can really think of sending him to surgery. And also the patient needs, if we if we agree with the early surgery, the patient needs to be aware of potential suboptimal surgical results, surgical morbidity and mortality, the fact that he may end up with a mitral prosthesis, which is very bad, and the potential need for redo of mitral valve surgery because of low durability of repair. But I agree, since the guidelines, as I showed you, the American guidelines became a bit more strict in recommending early surgery, and the European guidelines are a bit more in favor, I suggest that me and Dr. Rosenach will also agree somewhere in the middle. I agree that watchful waiting is also an option. It is a reasonable option for severe, but less severe MR, certainly in non-flared patients. In patients that are very far from the current guidelines cutoffs for intervention, that are patients that are active and truly asymptomatic, with not good LV function, excellent LV function, left ventricular end-systolic diameter much less than the 40, certainly to 45 millimeter range, patients with normal or even mildly elevated PA pressure, and certainly an elderly patient in which cardiac surgery is not a real easy game. Definitely, watchful waiting is the preferred option in patients with complex valve pathology and when the surgical experience is not good enough, because if the chances of valve repair are less than excellent, and again, I don't think it should be for overall all the patients. It can be also for a subset of patients with specific pathologies. Can you correct this P2 in more than 90%, maybe not? If the answer is yes, you can go for it. I don't mean that all mitral valve repairs will be 100% successful, because no doubt, watchful waiting for a patient who's asymptomatic and has no clear indication for surgery is certainly a better option than mitral valve replacement. Thank you very much.